morning, everyone. I'm Chris. I'm one of the EMI interns. Today I'm going to be talking about pre-post intubation and giving a brief overview. I just want to thank everyone who helped me put this presentation together. So the case is of a 55-year-old obese man. He was found unconscious in the bathroom. He has a GCS of 7. His vital signs are heart rate of 130, blood pressure of 90/55, respiratory rate of 28, and setting to 89% of room. So there are a few things you want to consider in your patient that might factor into how you manage their airway. So one is their vitals. This patient is hypotensive, he's tachycardic, he's tachypnic, and hypoxic. You also want to consider his anatomy and body habitus. This can help predict difficult airway, and it can also play into how you position the patient. And lastly, you want to consider their underlying condition. A patient who is in respiratory distress from asthma versus something like septic shock, for example, will have different management in terms of resuscitation, preoxygenation, medications, and bed settings. So for objectives, we're going to introduce ways to optimize pre-intubation conditions. I'm going to break that up into 4 different categories, and then I'm going to touch upon post-intubation management. So the first thing you want to do, even before the patient arrives, is to organize your equipment and medication. It's also good practice to brainstorm with your team and envision how you might manage the patients based on the EMS notification, especially since a lot of the patients that are coming in will be undifferentiated. So certainly use a mnemonic to help you create a mental checklist of all the items that you might need. So as for suction, you have your oxygen, airway equipment, position, monitor, meds, and ETCO2/others. So we have our suction, we have our airway oxygenation equipment, we have our airway equipment. You want to make sure you have MAC 3 and MAC 4, and for ETTOs you want 2 of them. One of them should be the predicted size, and the other one should be 1 size below. And then your backup airway equipment, so your bougie, your LMA, your tri-kit, your ETCO2s, tape and syringe. And you want to make sure that all your equipment is ready and working beforehand. So make sure you inflate the cups beforehand, check the blade lights, have the video laryngoscope plugged in and working, make sure the suction oxygen is also working. So the next thing you want to do is quickly assess the patient's airway. Dr. Agnor gave a great talk about this already, but to quickly go over it, the lemon is a way to anticipate difficult airways, and it reminds us that RSI is not the ideal approach for all patients. So you want to look externally, look for signs of facial trauma, large incisors, facial hair, large tongue. You can evaluate using the 3-3-2 rule for the patient's airway structure and see how far up their larynx is. But you want to be able to fit 3 fingers between the patient's incisors upon mouth opening, 3 fingers from the chin to the hyoid, and then 2 fingers from the hyoid to the thyroid cartilage. I'll touch upon the Mullen-Plotty score shortly. You want to check for obstruction or obesity. So stridor, foreign bodies, other forms of self-interpolatic obstruction. This can include tumors, abscesses, expanding hematoma, or inflamed epiglottis. And you want to check for neck mobility. This is especially important in trauma patients where C-spine injury is suspected. So on the top is the Mullen-Plotty score. It's a way to predict difficult airway based on what you see in the back of the patient's throat. And the Mullen-Plotty class tends to correlate with the Cormack-Leon grading, which you see at the bottom. And the Cormack-Leon grading is just another way to predict difficult airway based on what you see at the level of the vocal cords. Again, these are all just ways to help predict difficult airway and see if RSI is right for the patient. When intubation is indicated, my mind automatically jumps to the actual act of intubating because intubation is part of A and ABCs. But there are crucial steps pre and peri-intubation that you want to address before jumping right into intubation. So for a number of reasons, the peri-intubation period is a time of high cardiovascular collapse. EMCRIT has a nice article about the hot killers, which are physiologic killers that can lead to high risk for peri-intubation cardiac arrest. So the H stands for hypotension, O is for oxygen or hypoxemia, and P is for pH or acidosis. So you want to make sure you resuscitate before you intubate. Remember, slow is steady and steady is fast, because optimizing pre and peri-intubation conditions are essential. And critically ill patients often have all three of these conditions, hypotension, hypoxemia, and acidosis. So for hypotension, it's important to stabilize the blood pressure prior to and during intubation. These induction agents can drop blood pressure. You're also changing the patient to positive pressure ventilation, so that can further decrease their venous return. And paralytics take longer to work in a shock state. A lot of times they're cardiac output dependent, their efficacy is. So you want to shoot for a blood pressure systolic of at least 140 if possible before intubating. You can start with fluids or in trauma cases, blood. If the patient is not responding to your initial interventions, you can consider pressors. Peripheral pressors are safe and effective. You can start off with more epi, but if that's not readily available, you can make push-dose epi. And you do that by combining 1 milliliter of code epi and mixing it with 9 milliliters of normal saline. Just label the syringe, and if you're anticipating a patient who's coming in hypotensive and needs intubation, make sure to draw this up beforehand. For acidosis, acidotic patients require very high minute ventilations as part of their respiratory compensation. They're at high risk for decompensation, both during the apneic phase and post-intubation if the vent settings not able to match their high minute ventilation. So you want to pause and check the respiratory rate of every patient before intubating them. So if they're moving in air quickly, you want to think about metabolic acidosis. And you should also have end-tidal CO2 on your patients because it adds another objective measure to their respiratory effort. So if metabolic acidosis is suspected, the best strategy for these patients is to delay the intubation. If at all possible, you can temporize with non-invasive positive pressure ventilation and try to fix their underlying condition. So you want to think about things like drug overdoses or DKA. There's controversy surrounding the use of bicarb, but current guidelines don't recommend its use. Bicarb is metabolized into carbon dioxide, and a lot of these patients are already ventilating, have compromised through their respiratory effort. So further accumulation of carbon dioxide can cause cellular acidosis. If all else fails and the patient needs to be intubated, just make sure their vent settings match their high minute ventilation requirements. Then I'll talk about hypoxemia now. So you want to preoxygenate all patients requiring intubation, but it's especially important for hypoxemic patients. So you can start with 15 liters of non-respiratory breather plus 15 liters of nasal cannula. And the idea is to wash out the nitrogen at the alveolar level. You want to make sure you create an oxygen reservoir for these patients. Here's a picture of the nasal cannula plus the NRB. If the patient is still desatting despite supplemental oxygen, you want to think about shunts. So you can think of CHF exacerbations, ARDS patients, or diffuse pneumonia. And you can preoxygenate them with BiPAP or BVM with PEEP. The idea is to give them PEEP so that there's maximal alveolar distension and recruitment. If the patient is apneic, you preoxygenate with BVM with 15 liters of nasal cannula. And you want to give them proper preoxygenation because it prolongs the duration of safe apnea time during intubation. You also want to do manual airway maneuvers. This includes the jaw thrust and the head tilt chin lift maneuver. The jaw thrust is one of the most important techniques to help open up the upper airway. You lift the mandible towards the ceiling until the lower incisor is anterior to the upper incisor. And the head tilt chin lift maneuver, by doing that, the neck will naturally extend. But you want to be cautious of that in C-spine patients. And then for positioning, picture A shows a sniffing position, which we're all familiar with. The idea is if you flex the neck and extend the head, it'll help open up the airway and also provide optimal glottis visualization. You can further improve oxygenation by elevating the patient's torso, which helps offload weight from the tissue and also optimizes air filling into alveoli. So picture C shows the correct ramping position. So it maintains and also combines the sniffing position along with the elevated torso. And that allows for increased FRC, reduced oxygen desaturation, and improves your life. And this is what it looks like on an actual patient. Lastly, raise the patient to the level of your comfort. This can be anywhere from your umbilicus to your xiphoid. So back to our patient, after using basic airway maneuvers, we were able to appropriately resuscitate and preoxygenate him. His vitals improved, but because he remained unconscious, we're going to proceed with intubation. So last week, Dr. Sherban gave a great talk on RSI, so I'm not going to be covering that. But once the RSI medications are given, the patient's now ready for intubation. Here are a few tips that some of my senior residents and attendings gave me about intubation. So you want to wait until the jaw is loose from paralytics and scissoring becomes easy. You want to verbalize everything you see from the moment you're ready to administer medications to the moment you visualize the tube passing through the vocal cords. You want to make sure you communicate that to your team. You want to go deep into the vallecula. Here's a picture of a sagittal view of a cadaver, and you can see how deep the blade is going. And the deeper you go, the easier it is to pop the epiglottis anterior. You can use the Burt maneuver or the backward, upward, rightward pressure maneuver. And that's a useful skill to help facilitate glottis visualization. This self maneuver is no longer used, and it was initially believed that applying correctly pressure can compress the esophagus and prevent aspiration, but subsequent trials have shown no benefit and actually suggest harm. And once the tube is in, don't let go until confirmed and secure. As I mentioned before during the preoxygenation slide, you can continue to use the nasal cannula up to and through intubation. This will help prevent hypoxia during it, even in extreme clinical cases. And once the tube is in, you want to confirm with Untitled CO2, tube condensation, breath sounds, chest rise, chest x-ray, and the ultrasound. No tube confirmation technique is perfect, so you should use multiple. And lastly, post-intubation. Again, Dr. Sherban gave a great presentation on post-intubation analgesics and sedatives, but a few other points. You want to make sure you give analgesia first. You can start with a bolus of opiate and then titrate to a drip. But the idea is that poor pain control and too much sedation both lead to poor outcomes for patients. So patients who receive deep sedation early on in their course have been associated with increased delirium, longer ICU stays, and increased mortality. And good analgesia also allows for lesser sedative doses and side effects. Of note, rocuronium has longer duration effect. So patients who receive rocuronium may seem like they're receiving enough analgesia and sedation. That can lead to a delay in the administration of these medications. And you want to titrate the sedative drip to a RASS score of usually 0 to -2. The goal is usually light sedation where the patient is drowsy, but will still respond to voice. But depending on the patient's clinical scenario, you might want a lighter or deeper sedation. So if the patient requires like frequent neurochecks, you might want a higher RASS score. And lastly, don't forget the vent settings and OG. So to summarize, for our patient, we organized the equipment and medications by using SOCME. We quickly assessed the level of airway difficulty using Lemon. We had the proper backup equipment readily available. We elevated the head of the bed to 30 degrees, inserted an NPA, applied draw thrust maneuver, which improved his breathing, and we further preoxygenated him with non-respiratory breather and nasal cannula at 15 liters. We further resuscitated with push-dose epi, normalized his blood pressure. Remember the hop killers for that. We gave him the proper RSI medications and intubated with continued use of 15 liters of nasal cannula. And then for post-intubation, we applied lung-protected vent settings. OP bolus was given and titrated to a drip. And patient was sedated to a RASS score of -2, and an OG tube was placed to prevent aspiration. These are my references.